Good morning, ladies and gentlemen, members of the media. Thank you for joining us for the Ministry of Health and Wellness's press conference as we update the country on the outbreak of dengue fever. This morning, we have the Honorable Minister of Health and Wellness, Dr. Christopher Tufton, who is joined by our Chief Medical Officer, Dr. Jacqueline Bisesa McKenzie, as well as Mr. Michael Williams, Director of Environmental Health, and other directors of the Ministry of Health and Wellness in person and online. I'm Kedisha Watkins, Senior Public Relations Officer in the Ministry of Health and Wellness. We will begin the press conference with remarks from the Minister. Dr. Tufton? Yes.
And everybody will be good? Okay, excellent. That's good?
You may go ahead, Minister.
All right, okay, fine. So thank you very much. Ladies and gentlemen, good morning to you all. Happy Thursday. So today we will, as said, give an update on the status of the dengue outbreak that we have been experiencing for some time. So the ministry declared the outbreak on September 23rd, 2023. The outbreak was confirmed when the National Surveillance Unit advised that Jamaica had surpassed the dengue epidemic threshold for several months, and there is a lag time, so we would have had to, the incident of exceeding that would have had to occur before it would have been captured, recorded, and reported on. The cases for dengue remain above the epidemic threshold. As of November 6, 2023, the National Surveillance Unit in the Ministry of Health and Wellness recorded some 3,147 suspected, presumed, and confirmed dengue cases. Currently, the National Surveillance Unit has on record 870 PCR confirmed cases of dengue fever, while dengue serotypes 2, 3, and 4 have been identified among the population. It is the type 2 that remains the dominant strain. At this same time, there have been 9, unfortunately, dengue-related deaths, 7 classified as suspected, 2 as confirmed, and no deaths have been recorded in the past 2 weeks. The 5 to 14 age cohort continues to be cause for concern with the highest number of suspected, presumed, and confirmed cases observed in that group, represented by a ratio or a rate of 360.3 cases per 100,000 population. In terms of geographic distribution, all parishes continue to observe an increase in dengue cases compared to 2022, with Kingston and St. Andrew reporting the highest number of cases, 776 for 2023. At the same time, St. Thomas maintains the highest rate of cases, 382.5 per 100,000 population, followed by Portland, 221 per 100,000, and Trelawney with 160 per 100,000. In terms of hospitalization, within the last week, an average of some 72 persons have required hospitalization. The Chief Medical Officer, who sits to my left, Dr. Bisesa McKenzie, will give us more details on the national picture of the impact of dengue across the island and appraise us further on how we're coping in terms of the hospitalization and the response from the healthcare infrastructure perspective. So I'll just hand over to Dr. Bisesa McKenzie for that.
All right. Thank you, Minister. Good afternoon. Good morning, everyone. We're going to be looking at the slides. And you are... Okay. They're blocking the slides. All right. Okay, so just a brief overview. Dengue was first described in Jamaica as a distinct disease in 1943. And all 4 serotypes have been identified and have caused outbreaks. You have heard us talking about serotype 2 being prevalent at this time. There are 4 serotypes, 1, 2, 3, and 4. All 4 serotypes have been identified and have caused outbreaks since 1943. The largest reported outbreak was in 1977, and that was with type 1. Dengue outbreaks have become more frequent. If you look at the picture there, you will see where the numbers are, that the outbreaks have become more frequent compared to, say, between 1995 to 1998 and up to 2007. And then since 2007, you would see that the outbreaks are becoming more frequent. You will also see from the graph that the number of cases in the inter-epidemic period have increased. So a greater proportion of dengue-related deaths have also been observed. And these are features of what we call hyperendemicity, meaning more frequent outbreaks, and in the baseline, you have higher numbers of dengue. Even when we don't reach past the outbreak threshold, we have more cases. So this is what we refer to as hyperendemicity. As at November 6th, as Minister has said, the National Surveillance Unit has recorded 3,147 suspected, probable, and confirmed dengue cases. 870 of these have been confirmed, and 863 are dengue serotype 2. 1 co-infected with serotype 2 and 3, 4 serotype 3, and 2 serotype 4. So clearly, serotype 2 is the most prevalent. 9 dengue-related deaths were classified to date, 2 were confirmed, and 7 suspected. This is the weekly distribution of dengue cases, and you will see that in epi weeks 37, 38, 39, 40, peaking at 39 so far have been the highest number of cases. And epi week 38, 39 would be about the end of September. Next slide. When you look at it monthly, you can see that by far September has had the highest number of cases. And I just want to point out here that we do receive notifications late. So even though we are seeing October being less than September presently on the graph, as we get in more notifications, that may change. So we may see the peak remaining in September, but it may change as the numbers come in and October numbers may rise. In terms of geographical distribution, all parishes are affected. In particular, you will notice in red that Kingston and St. Andrew and St. Catherine have the highest number of cases. These are the most dense parishes, and so therefore more highly populated, so more cases there. However, in terms of rate per 100,000 population, St. Thomas, followed by Portland, is where you're seeing the higher numbers. Next slide. In terms of the parish dengue cases, in terms of when we have seen the highest numbers, again, across all parishes, the latter part of September, early October would have been when we have seen the highest number of cases. And you can see that in epi weeks 37, 38, 39, and 40. Next slide. And again, this shows you in terms of looking at each parish, the histogram to show you where the peaks have been so far. In terms of looking at a comparison of dengue cases from 2016 to 2023, you would see that for 2023, year to date, we've had 3,147 suspected, probable, or confirmed cases. And this is in comparison to 2019, when we had 9,913 for the year. That was our last outbreak. And then before that, in 2016, 2,297. So we would have surpassed so far for this year the 2016 outbreak numbers, and we would be at about a third of the outbreak numbers in 2019. In terms of confirmed cases, you can see that by far the number of confirmed cases at 870 is a lot more than we had in the previous years. And this is, in fact, because of our increased capacity at the National Public Health Lab to test. I don't know if you recall that in 2019, we had to depend quite a bit on results coming in from the Caribbean Public Health Agency in Trinidad, and there was a long delay in getting results. Now we are getting results within 48 hours, and you can see the higher numbers of test results that we are getting. Next. In terms of hospitalization, following the number of cases that we are seeing in terms of the rise and the highest numbers in September, we are also seeing that is what is happening in terms of hospitalizations. The highest numbers we saw in September, we are seeing the trend going down now. However, I must say that we do have some delay in reporting from the hospitals. We have established a system, an electronic system for the hospitals to report in. I think some of the hospitals are still getting used to that system, so we don't have full reporting by them, but we're hoping that very shortly we will be able to have real-time reporting on the number of cases that are coming into the emergency department. So the numbers that you are seeing here are looking at the notifications. Of the notifications that we get, how many are hospitalized, and we certainly would have seen an increase in September. In terms of age and sex distribution, the 5 to 14 age group are where we're seeing the highest numbers, and this is followed by the 1 to 4 and then the less than 1 age group. And this is in keeping with the fact that type 2 dengue, we have not seen it being prevalent for just about 10 years or just over 10 years. And so you will find that persons in those age groups have not previously been exposed to dengue type 2, and so therefore there's a higher likelihood that they would be infected. And I just wanted to take this opportunity to refer you, the web page is noted there, to our Special Vitals publication on dengue, where you can get additional information on dengue over the years in Jamaica. Thank you.
Thank you very much, CMO. So just to continue with the update, in terms of the vector control unit, we continue to take steps to mitigate the impact of dengue on the population, inclusive of the following: fogging, waste removal, and drain cleaning. So the ministry, you may recall or have seen, began distribution of drum covers in areas with high water storage. More than 500 have been distributed. Fogging sessions continue across the island, both morning and evenings, with a total of 461 communities fogged to date. An additional 115 high-risk communities have received fogging. We have partnered with the National Solid Waste Management Authority to remove bulky waste in an initial 6 parishes. Bulky waste has so far been removed from more than 20 communities and approximately 20 major drains cleaned. And the areas, by the way, have been determined based on where the index is highest and where, therefore, the risk because of the breeding sites for the Aedes aegypti mosquito are greatest. Approximately 700 temporary vector control workers are already employed across the island and engage in search and destroy and health education. In terms of the equipment and the use of the equipment, to enhance fogging capabilities, the national program undertook the repair servicing of all the defective ULV machines across parishes. To this end, 2 officers from Clark Mosquito Product, the manufacturers of the ULV machines, visited the island during October to assess the machines and to repair as necessary. Members of the National Vector Control Team also received training in the servicing and proper calibration of the machines, and health promotion teams continue to carry out community public health education initiatives across the island. I'd like to use the opportunity just to remind members of the public that dengue fever is a mosquito-borne disease, as said before, that is usually a mild illness. in which a person may experience a fever, headache, joint and muscle pains, and that rest and adequate hydration are usually enough to see one through the period of illness. The recommended treatment for the fever is paracetamol. The public continues to be urged to not to use aspirin, diclofenac, ibuprofen, or any of the medication pain relievers known as non-steroidal anti-inflammatory drugs. In other words, get your doctor to advise if you are not sure as to what to take. These drugs, when used to treat the fever in dengue, have been known to increase the severity of the disease, including bleeding, which can be a lot more detrimental to your health. On occasions, of course, the illness can progress to severe dengue, which can result in organ failure as well as bleeding, severe fluid depletion that can lead to shock, and unfortunately can lead to death. Persons experiencing fever, vomiting, severe abdominal pain, bleeding under the skin, feeling very weak or getting confused are advised to immediately seek medical attention. Members of the public are urged to play their part in ensuring that the cases are minimized by monitoring water storage containers for mosquito breeding, keeping surroundings free of debris, destroying or treating potential mosquito breeding sites, wearing protective clothing, and using a DEET-containing mosquito repellent. These are all things that we have said before, but it's worth repeating, as today is not just an update, but it's a reinforcement of the messaging around dengue. It will run its cycle. And there are things that we can control to influence or shorten that cycle. There are things that may be environmental that we don't have full control over. You know, whether it's the warmth or the cool, the rain, the need for storage. Those are things that we can seek to manage, but not totally control. And so it's up to us significantly to protect ourselves, but not totally up to us in terms of the cycle that will run its course. And we do anticipate, based on the epidemiological assessment, that we will continue to see the presence of the virus and perhaps on the rise going into the end of this year, and then dissipate over time in the first quarter of next year. I want to just make one final point before we open the floor. I did take note that it is being said that there are more cases than is being reported. I believe it was the opposition spokesperson who said that. And I think that's reasonable to assume, because you never really capture all the cases. And in instances where those cases are mild, many persons opt to self-treat, or even if diagnosed, they, take the time to rest, to rehydrate, and so on. Remember now, a lot of the cases most of the cases will be mild cases, and with proper treatment and rest, you can get over them. It is the severe cases that end up in the hospital system or in the healthcare system. So I don't think that is a new discovery. Epidemiologically, there is a ratio of detected cases through testing and cases that go undetected. In COVID, they say it's probably 1 to 6 or 7, something like that. I'm sure dengue also has that ratio. So that is not a cause for alarm. It is almost an expectation. And what is more important is that we provide the guidance to the population so that persons are aware that this is out there, it can be potentially dangerous, and we should protect ourselves. And our role, it is to give that information, to help you to identify the sites, to respond, to protect yourself, and to have the hospital system that will give you some support. I want to say one other thing. I know the CMO spoke to hospitalization. We do have overcrowding in a number of our hospitals, particularly those in the urban centers. and overcrowding, particularly as it relates to accident and emergency, because there are several things within the environment that are happening at the same time. And once you have a spike in one particular area, it does amplify the need for bed space, for attention, and thereby creates, through the triaging process, the need for wait and longer waits. The institutions are relatively predictable based on historical data. The Spanish Town Hospital, University Hospital of the West Indies, Bustamante Hospital for Children, SAV has its fair share, Cornwall Regional, and perhaps even St. Anne's Bay. The problem is further amplified by bed blockers, for want of a better terminology, social cases that occupy bed space, and that continues to be a major issue. But we're trying to manage it. But I raise it to say the public should be aware that A&Es, certainly in those urban centers, are likely to have waits and extended waits. However, the triage process, which will see an initial assessment of the patient coming in to determine the severity of their condition, should ensure that those who need the assistance most, those who are suffering from life-threatening illnesses, they get that assistance first. It therefore means some may come and see others being treated before them. They may perceive it to be unfair under the principle of first come, first serve. Accident and emergency wards don't operate on a first come, first serve basis. It operates on a triage process that gives first attention to the most severe cases. And that is going to happen and will become apparently more so over the next number of months, going into the Christmas season and perhaps even into the new year. We are making some efforts to rearrange and to adjust, to accommodate or to lessen the burden. So, for example, we had a meeting recently with the management of Spanish Town Hospital. They came in. Actually, that was the fateful day of the earthquake. We were in the middle of that meeting in our boardroom on the 7th floor, and the earth shook while we were dialoguing around what to do at Spanish Town Hospital, which included all the management of the Sierra and the management of Spanish Town Hospital. And since that time, there have been attempts at moving some patients to the National Chest Hospital, which was a decision we took. There's a discussion taking place as it relates to Bellevue Hospital, because there are about 29 acute mental health patients that have occupied beds there. And so, and some other things that are being done to hasten the process of triaging, releasing, and dealing with the cases so that we free up the wait. When we had that discussion, I think we had about 70 or 80 persons waiting for a bed at the Spanish Town Hospital. I mean, they were seated in chairs, sometimes lounge chairs, sometimes they were even on a bed, but in an area that is not considered a ward. And we understand the challenges and certainly empathize with those persons who have to experience that particular situation. But unfortunately, there is not much more we can do at this point in time except try to manage as best as possible, which is why it's important. If you don't have to go to the A&E, don't go. Check with your doctor at the health center, your private doctor, and to the extent that you can be guided and medicated and rest and recover at home, that is the preferred option, which I believe most persons would prefer anyway. So that's the update. We now open the floor for questions or comments. We have a team here. Mr. Michael Williams, our environmental specialist, who can give more information on the vector management process, the team, the fogging, all of that, and of course the CMO. So thank you very much.
Thank you for the update, Minister and CMO. So we're inviting our media colleagues in the room and online to present your questions. If you are online, we ask you to use the raise hand feature, following which we will acknowledge you. Yes. We ask you to introduce yourself and present your question to the head table.
Morning, everyone. Romar the Lion, Stevie J. Mr. Tufton, some weeks ago you urged citizens to not attack the vector workers when they enter the communities. Just an update on that. Are people more receptive to the people entering the communities to do the fogging, or are you still getting reports of attacks?
I have not had any reports of any adverse response to personnel. I've had reports of adverse response to the fogging. Maybe Mr. Williams can give some better particulars if he has had any reports, because they are technically under his oversight, if you will, and tell us exactly what the situation is, and then maybe comment a little, if you will. I'm not playing reporter now on the fogging, because I've heard persons say it is killing the bees, or it is amplifying their sinuses or asthma and so on. I mean, you may want to comment on that. Just turn on your microphone, please.
Thank you very much, Minister. So what has happened in the past is that we have had attacks in the past where persons who assembled in the community and the vehicles came through, and because of the odor that came from the spraying, and they did not want to move or, allow the spraying to continue, we have had a few attacks in the past. But recently, we have not had a sustained attack on the vector workers conducting their activities. What we encourage people to do, and we have persons who close their windows and doors, which defeats the process, because the Aedes aegypti is a day-biting mosquito, and you're going to find him in your home, under your table, in dark places, in your closet. So, of course, you want the insecticide to go into the home. So closing the windows and door defeats the whole process. So we encourage the public, whenever the vehicles are coming around to spray, open up the windows and doors and allow the insecticide to come inside so that the vectors can be destroyed. Persons who have problems with sinusitis and respiratory issues, we advise that they use a damp towel to put over their faces while the vehicles have passed with the spraying. And it dissipates quickly, It doesn't remain in the environment for long. So this, along with other actions, will help to control the vectors.
So essentially what if I may be so presumptuous, what he's saying is that we have not had an attack or no reported attacks in recent times. But I know I've personally had calls and WhatsApp from persons questioning the health effect or impact of the fogging. And so I think his advice is important to take. I want to say something on fogging, though, because there are a lot of people who think that fogging is the solution to the mosquito population. It is a very, very temporary solution. Indeed, the cycle of the breeding and the life cycle of the mosquito, which, again, Mr. Williams can comment on, allows thousands of mosquitoes to be released in the atmosphere on a daily basis. And a fogging cycle will give you a very temporary relief. So we treat the water also through the visits of the vector workers. So they look for the little wiggly thing and they'll put a tablet in there and it purifies the water or destroys them. That's important, very important. But the call for fogging every day may do you, well, maybe I shouldn't say that, maybe something you don't want, right? It's more important to protect your environment and the breeding within and the vase on the table and the drum in the backyard and so on. Those are the more important things. So I don't know if you want to elaborate a little on that, just to say to persons, while we are doing the fogging, the more important things to do are 1, 2, 3.
Definitely. So the vector has 4 phases in the life cycle. There is the egg-laying phase, which is number 1. You have the larval stage, the pupal stage, and then adults. So the mosquito, the vector, can be controlled at any one of these phases. And as Minister said, fogging is the final stage where we seek to kill the adults. So we have found out that the drums, especially the 55-gallon drums, is the primary receptacle for mosquito breeding. We have found most breeding in those drums. And so we encourage persons to cover the drums. We have a program where we're going to introduce drum cover, but in the meantime, use a cloth, use an old sheet to cover the drums. Put some oil on the surface of the water, because the larvae, they have to come up to breathe, and the oil will clog the breathing apparatus. So we encourage persons to protect their water supply. Garbage disposal is a big problem. So when we go to a home, because we have the team that goes out, normally we have a cadre of vector workers, about 400 during ordinary times. But when it comes on to the rainy season, we increase that to a little over 1,000. When the team goes out, what we find is that there is a lot of garbage pileup, juice boxes, cans, whatever. We have issues with garbage collection. And so we encourage the public to bore holes in the cans, crush them, put them in a bag until the truck comes. Sometimes the truck will come months later. We don't have weekly collection. But do your part to prevent the vectors from finding that receptacle to breed in. There's a lot that the public can do and must do. The fogging alone will not help. We have to do our part to control the proliferation of the vector in the environment. Just wanted to say too that there are persons who, with respiratory issues, and they close off their premises when the vector team is coming through. You can buy your own insecticide, the commercial ones, and they have some that are odorless. They're good too. And you start spraying from the back of the house up to the front before you leave in the mornings. So we can do a lot in curtailing the spread and in controlling the vector population.
Thank you very much, Mr. Williams.
Do we have any other questions?
Just one. So yesterday, the opposition spokesman on health also raised concern that the ministry is focused mainly in communities where the mosquito index is high. He's saying that there should be attention in the communities where it's low as to not create, and I quote, a disaster. So I just wanted your response to that.
Right. So it's not a matter of only focusing on the areas where it's high. I mean, yes, we do that because clearly where it's high, the risk is greatest. And there's always going to be a risk assessment to determine where the concentration of focus is. But there are several programs that we have embarked on to inform the entire population, like this one right here, communication. The vector workers who are in the field, the 700 workers, are not just in one set of community. They go right across. But it is true that they focus on areas that traditionally are areas where the index is high. And those areas are almost defined by practice and geography. So you have low-lying areas where water settles as a constant, semi-clean water where the mosquito breeding is most fertile. Okay, it breeds in clean water or semi-clean. Is that so, Mr. Williams? I sound like an environmentalist, but study the brief. So those. Then you have areas where there is no piped infrastructure, so people store water in drums. Then you have particular challenged areas where you have solid waste that is not properly managed for whatever reason. And then you have institutions because of the risk to the population, like the schools, where, as we said earlier, this type 2 strain is targeted or is more novel to the 5 to 14-year-old. So we go to the schools. So to suggest that we must not target is to suggest that we don't have a strategy, and we don't operate like that. So I'm sure that's probably not what he meant. He couldn't have, because any problem requires an approach and a strategy and a response that prioritizes based on the risk profiling. And that's what we have done. But the entire country is aware of the dengue outbreak. The entire country is being promoted about the do's and the don'ts, the symptoms, and then we target specific areas based on where the risk is greatest. You wanted to say something on that? The CMO wants to say something, Madam Chair. Go ahead.
Yes. Right. I just want to say that we are experiencing, as the Minister said, an overcrowding in our hospitals and in our emergency departments. And I really want to commend the healthcare workers who have been working diligently to manage the increased caseload that they're seeing at each hospital. I do not want to discourage the public from attending the emergency departments, but for milder cases, that these can be managed at home and you can seek care in primary care services. But we have been seeing that more persons are coming in with early warning signs to hospitals, and that is good, because what we are seeing this year are less deaths than we have seen before. And it means that the messaging, persons are receiving the messages. They are, when they detect early warning signs, which is that if you have persistence of your fever, or when your fever has settled down, you recognize that you are not getting better, you are having vomiting, abdominal pain, other gastrointestinal symptoms, feelings of lethargy, just want to stay in bed all the time, you become dehydrated. All of these things are early warning signs, and you must seek medical advice. So far, we have been seeing that persons have been coming out to the healthcare practitioners, and we are able to manage the patients. So I just want to encourage the public further. And as I said, I know that we are seeing an increased workload in our health services, but I really want to encourage the doctors and the other healthcare workers that I know that it's all hands on deck at this time as we get through this difficult period, but certainly we are seeing the benefits of it as we are seeing less poor outcomes. And every death is a very serious matter. It affects us all, not just the family, but the entire country, and we don't want to see any more deaths related to dengue. Thank you.
Thank you, CMO. We have another question.
And Sashana Small from the Jamaica Gleaner. Minister, you mentioned that there were 19 at-risk communities, or a number of at-risk communities. Can you tell us how often these communities are fogged and where they're concentrated, like in parishes?
Right. So I probably would yield to Mr. Williams on that. I know a study was done which led to how the particular allocation and starting point was. It's a moving target, obviously, but that's, you wanted to comment on how that process works?
Okay, so we have 500. Sorry, we have 500 high-risk communities. So these are communities that you have a heavy reliance on containers for water. They might not be piped water. Garbage collection is an issue, and among other things. So these are priorities. We have done to date 115 high-risk communities, and we continue to go back and to include places where you have like tire shops and other facilities that will contribute to the mosquito breeding, heavy mosquito breeding. If there's a dump site in the community, we focus on that, the tire shops and places where there is uncollected garbage. Also, another thing that dictates where we go to do the fogging is the epidemiology data. So if we know that cases are in a community, of course we will concentrate our efforts in that and adjoining communities to prevent the spread. So the teams continue to go to the high-risk communities, and apart from doing the fogging, let me just inform us that we have the team that does the larvicidal work, which is the most important because they are in the communities to identify the breeding sites, to give out the pamphlets, and to talk to the community members about control and prevention measures. So the larvicidal team is really the workhorse of the dengue program. As they go into the community and they identify where breeding is taking place, help the community members to deal with the breeding sites. If more work needs to be done where you have like water settling in parts of the community, swamps and those things, it is related. And we do what we can working with like National Work Agency, the Member of Parliament, to do something to alleviate these situations. So yes, the high-risk sites, we target them and we continue to visit, and also wherever we have cases, these are the priority areas that we really go to do a lot of the work, including fogging, but larvicidal work also.
But just to be clear, there is no set schedule as to how the fogging is done? Meaning
Yes.
like on a weekly basis?
Definitely.
Every 2 days?
So we do fogging morning and evenings, and as I said, the epidemiology data guides us. So wherever we have cases, we concentrate in those areas, as well as where we have the high-risk communities, because we know that there is a high concentration of water containers where there's not pipe water, so people are storing water. So the larvicidal team, even if you don't see fogging taking place in those communities, the team that does larvicidal work, they are in those communities.
All right, and we thank you for those responses, Mr. Williams. Are there any other questions? Okay, I see no questions online, Minister, and in the room we have had the questions from our reporters answered. So we want to thank you for joining our press conference. Thank you, Dr. Tufton. Thank you to our Chief Medical Officer, Dr. Jacqueline Bisesa McKenzie, Mr. Michael Williams, Director of Environmental Health, our colleagues here in person and online. Members of the media, we thank you for joining us.